Emphysema. The basics. Definition, pathophysiology, and risk factors. 1. Definition. Destruction of alveolar walls. Abnormal enlargement of air spaces. Emphysema is defined as the abnormal and permanent enlargement of air spaces distal to the terminal bronchioles, accompanied by the destruction of the alveolar walls. Not just air trapping. It is not merely about air trapping or inflammation, but about the irreversible destruction of lung tissue, resulting in enlarged air spaces and loss of lung elasticity. Part of COPD. Emphysema is one of the two major pathological entities that comprise chronic obstructive pulmonary disease, COPD. The other is chronic bronchitis. Note: understanding that emphysema is an anatomical and irreversible change in the lung tissue is crucial. 2. Pathophysiology. The mechanisms of alveolar destruction, inflammation, and protease-antiprotease. Imbalance. Chronic exposure to inhaled irritants, primarily cigarette smoke, leads to chronic inflammation in the lungs. Note: this is the primary mechanism of emphysema. Release of proteases. This inflammation causes the release of proteases, enzymes that break down proteins, such as neutrophil elastase. Deficiency in antiproteases, a normal state of balance between proteases and antiproteases, such as alpha-1 antitrypsin. However, when there is a deficiency or an imbalance in the enzymes, this leads to tissue destruction. Alveolar wall destruction. Neutrophil elastase and other proteases digest and destroy the walls of the alveoli. Note: the destruction of the alveolar walls is the main feature of emphysema. Loss of elasticity. The destruction of the alveolar walls leads to a loss of elastic recoil in the lungs, which is the ability of the lungs to passively collapse. Air trapping and hyperinflation. The loss of elastic recoil and destruction of lung tissue leads to air trapping and hyperinflation, particularly during exhalation. Impaired gas exchange. The damage to the alveoli reduces the surface area for gas exchange. Small airway collapse. This can lead to airway narrowing and collapse, particularly in the small airways. Note: the pathophysiology involves an imbalance of proteases and antiproteases, leading to tissue damage. 3. Risk factors. Identifying the vulnerable patient. Smoking. Most significant risk factor. Cigarette smoking is responsible for the vast majority of emphysema cases. Dose-response relationship. The risk increases with the duration and intensity of smoking. Note: smoking is the most important modifiable risk factor. Alpha-1 antitrypsin deficiency, a rare genetic disorder that results in a deficiency in the A1AT protein, which can lead to early-onset emphysema. Note: it is important to assess for this if the patient is young or does not have a significant history of smoking. Age. The risk of emphysema increases with age. Occupational exposures. Prolonged exposure to dusts, fumes, and other irritants. Air pollution. Long-term exposure to air pollution. Genetic predisposition, family history of emphysema. Note: understanding these risk factors can help in prevention and early diagnosis. Clinical manifestations and diagnosis. Recognizing and investigating emphysema. 1. Clinical manifestations. Recognizing the signs and symptoms. Dyspnea, shortness of breath. The most prominent symptom that is usually progressive and worsens over time. Chronic cough. May be present, but not always a prominent symptom. Sputum production. May produce small amounts of mucus. Wheezing. May be present due to bronchoconstriction. Barrel chest. Increased anterior-posterior diameter of the chest due to hyperinflation. Note: classic finding in advanced disease. Pursed lip breathing, a breathing technique used to reduce air trapping by slowing exhalation and reducing airway collapse. Decreased breath sounds. May be present on lung auscultation, especially in areas of emphysema. Weight loss. May occur due to increased work of breathing and decreased appetite. Use of accessory muscles, using the neck and upper shoulder muscles to help breath. Tripod position. Patients with severe dyspnea may lean forward with their hands on their knees in an attempt to make breathing easier. Note: the clinical presentation of emphysema can vary widely and may be subtle in early disease. Note: symptoms typically worsen over time. 2. Diagnostic workup, a step-by-step approach. History and physical examination. Detailed history of symptoms, smoking history, and a thorough physical examination focusing on the lungs. Pulmonary function tests, PFTs. Spirometry demonstrates airflow obstruction with decreased FEV1, forced expiratory volume in 1 second, and decreased FEV1/FVC ratio. Note: the FEV1/FVC ratio is the gold standard diagnostic test. Reduced diffusion capacity, DLCO, impaired gas exchange. Note: the reduction in FEV1 and FEV1/FVC and diffusion capacity confirms airflow obstruction. Chest X-ray may show signs of hyperinflation, flattened diaphragm and bullae, or decreased vascular markings. Computed tomography, CT. Scan of the chest provides detailed images of the lungs and helps to assess for the type and distribution of emphysema and other complications. Arterial blood gas, ABG, may show hypoxemia, hypercapnia, and acid-base disturbances in more severe cases. Alpha-1 antitrypsin testing. If there is a high clinical suspicion for A1AT deficiency, such as in a young patient or family history. Note: a combination of clinical findings, PFTs, and imaging helps to diagnose emphysema. Note: early detection is important to begin treatment and reduce progression. Management. Strategies for treating emphysema. 1. Smoking cessation. Essential, the single most effective intervention to slow disease progression. Multiple strategies. A combination of counseling and pharmacotherapy, including nicotine replacement, bupropion, and varenicline, can help. Note: this is the most important step to help prevent further lung damage. 2. Pharmacotherapy, relieving symptoms and preventing exacerbations. Bronchodilators, beta-2, agonists, short-acting, for example albuterol, and long-acting, for example salmeterol, formoterol, to dilate the airways. Anticholinergics, short-acting, for example ipratropium, and long-acting, for example tiotropium, to block muscarinic receptors and cause bronchodilation and reduce mucus production. Note: these are the main medications for symptom control. Inhaled corticosteroids, ICS, reduce inflammation in the airways and improve symptoms of asthma, and are usually combined with long-acting bronchodilators. Combination inhalers, LABA/SS, long-acting beta agonist and inhaled corticosteroids, and LABA/LAMA, long-acting beta agonist and long-acting muscarinic antagonists. Phosphodiesterase 4, PDE4, inhibitors. Mechanism: roflumilast, a PDE4 inhibitor, reduces inflammation and mucus production. Note: used in a subgroup of patients with chronic bronchitis and frequent exacerbations. Note: there are many medications to control symptoms, but none to reverse the damage. 3. Oxygen therapy, supplemental oxygen, given to patients with severe hypoxemia. Note: shown to improve survival in patients with severe hypoxemia. 4. Pulmonary rehabilitation, exercise training, supervised exercise programs to improve exercise tolerance and quality of life. Education, to manage dyspnea and improve inhaler technique. Note: an important component of therapy. 5. Management of exacerbations, short-acting bronchodilators as needed. Corticosteroids, oral or intravenous corticosteroids. Antibiotics, if there is evidence of a bacterial infection. Supplemental oxygen, if hypoxemic. Note: treatment is focused on reversing symptoms and preventing further complications. Long-term considerations. The big picture. 1. Monitoring for progression, regular assessment of symptoms and lung function, spirometry. 2. Vaccinations, annual influenza vaccine and pneumococcal vaccination to prevent respiratory infections. 3. Management of complications, treatment of comorbidities, heart failure, and other complications. 4. Patient education, educate the patient on self-management strategies and recognizing exacerbations. 5. Palliative care, as needed to treat symptoms and improve quality of life. 6. Note: management focuses on symptom control, slowing progression, and preventing complications. Key takeaways for exam success and future practice. 1. Emphysema is defined as the abnormal and permanent enlargement of the air spaces with destruction of the alveolar walls, and it is a component of COPD. 2. Smoking is the major risk factor for emphysema. 3. Understand the pathophysiology of emphysema, including the protease-antiprotease imbalance. 4. Understand the importance of spirometry for diagnosis and chest imaging. 5. Understand the treatment options, including smoking cessation, bronchodilators, inhaled corticosteroids, Oxygen therapy and pulmonary rehabilitation. 6. Patient education and lifestyle modifications are essential aspects of care. 7. Remember that emphysema is irreversible.